members of NUPCI. I'm Elizabeth Ballerman, President of the Health Sciences Association of Alberta, one of the 11 components of NUPCI. Our member unions represent the employees of provincial governments, public agencies, and private employers. In addition to the provincial government unions, professionals, and brewery and winery workers, NUPCI includes 2 unions of healthcare in BC and Alberta. All provide a broad range of essential public services, and especially the brewery and winery workers. I was hoping you'd get that. So, social services, child protection, liquor control boards, and highway maintenance, corrections, healthcare, and some of the places where you'll find our members. With our overarching theme of All Together Now, we at NUPCI have been campaigning incessantly across the country for a better Canada, for more and equal society. That includes unequivocal support and advocacy for labour rights and great public services. Specific initiatives include the Canadian Foundation for Labour Rights and last year's Fairness Express, the big green bus with which we crisscrossed the country to talk to Canadians about income inequality. And I would point you to our ad in the program, in the middle, which reinforces what we all know, that unions matter. And of course, we are proud supporters of the Broadband Institute. So while it wasn't supposed to be like this, as the president of one of NUPCI's exclusively healthcare unions and the co-chair of its Canadian Health Professionals Secretariat, I am exceptionally pleased to have been tapped to introduce one of Canada's greatest defenders of public healthcare, the Honourable Roy Romanow. Who I'm sure is the reason you're in the room. Mr. Romanow served in public office in Canada for over 30 years, most notably as Premier of Saskatchewan from 1991 to 2001, and before that as Deputy Premier and Attorney General from 1971 to 82. An officer of the Order of Canada, Mr. Romanow is currently a Senior Fellow in Public Policy at the University of Saskatchewan. He was the head of the Commission on the Future of Healthcare that carries his name. Now, 13 years into the future, which I submit isn't quite as he envisioned in 2002, please join me in welcoming the Honourable Roy Romanow as he kicks off our panel on Medicare and the fight for Canadian values. The Honourable Roy Romanow.
Thank you. Thank you. Thank you very much. Thank you very much for the warm welcome, and a special thanks to Elizabeth for that very kind introduction. When I was in politics, every introduction was a bit different from others. This one was memorable in the sense that it was clean and right to the point. I remember one time being introduced in this fashion. Ladies and gentlemen, I want to thank the ladies. In those days it was ladies who were putting together the potlatch lunches for the New Democratic Party. Thank so-and-so, thanks. Now that all the good things are over, here's our guest speaker, Roy Romanow. And I proved her to be right. Thanks very much, Elizabeth, for a very nice introduction. I want to congratulate the Broadband Institute for its important work tackling some of the most difficult challenges facing Canadians today. And I particularly want to single out and thank Ed for his many years of distinguished service to this country in so many ways, confirming him as one of our nation's very most outstanding Canadians. We should be very proud to have him. Now, my task today, and I've got to get at it because there'll be panelists, is to discuss the future of Medicare in Canada and the role of our governments and the role they should play in ensuring that the principles of our most cherished social programs are upheld and strengthened. I want to begin with, not surprisingly, values and how we measure our achievements as a nation. What values are evident in our public universal health care plan? As I see it, treating each other with dignity and caring for each other in our time of medical need, and doing so no matter where one lives or what one's socioeconomic status, happens to be a key value. Medicare is based on the inherent worth of every citizen and affirms that we value medical care as more than just a commodity to be traded on the marketplace. Now, however, there seems to be a growing proliferation of voices attacking the efficacy of Medicare and this value and the values upon which it is based. In fact, some are even calling for the end of this extremely effective, and I describe it, nation-defining social program. So in the face of this growing chorus of criticism, I can understand how some Canadians may doubt the future of Medicare. After all, the challenges are real. For example, wait times for procedures, availability of programs, and the responsiveness of some services all indicate the challenges of the system. These are frequently highlighted by the press, and one can forgive Canadians for thinking that sometimes there is a problem with the overarching principles and efficacy of this great plan. Certainly, we have seen in the past couple of decades various provincial and federal governments avoiding key reforms, and all the while overlooking the additional burdens that Canadians go through because the reforms aren't implemented or because of increased privatization in the absence of these reforms. In this, those governments have been supported by well-financed institutions and individuals who have everything to gain through new market opportunities. Moreover, many provincial governments have accepted the role of being managers of this declining state of affairs. But I say to you, my friends, that history demonstrates so powerful and so powerfully that it need not be this way. Let me just take a moment to remind ourselves, if I may put it that way, of some of history's highlights leading to our achievement of health care and Medicare. First, let's not forget there was Tommy Douglas's principled leadership in establishing publicly funded Medicare in Saskatchewan. A difficult fight it was, and I can personally attest to this difficult period, but successful struggle to implement Canada's first universal publicly funded medical care plan. Secondly, Progressive Conservative Emmett Hall's landmark Royal Commission report of 1964, reflecting Canadians' thirst for universal Medicare, put this agenda squarely on the national scene. And third, there was a remarkable example of principled national leadership when then Prime Minister Lester B. Pearson transformed Medicare into a truly national program. And friends, it wasn't easy. Pearson faced an array of formidable opposition forces, from ideologically opposed premiers to well-entrenched and financial professional groups, and even, believe it or not, to a divided cabinet federally and his own minority federal government. I delivered a public lecture a few years ago at St. FX University in the name of Alan McEachern, and Mr. McEachern was asked to comment on my talk, the only time that he's been asked to do that, and he's done it, and I think the only time he's done it since. He described the situation facing Pearson. He was a member of his cabinet, facing Pearson and his cabinet and the nation. The provinces took advantage of the divisions within the federal cabinet. 8 premiers confronted Pearson with major complaints. Mr. McEachern summed up Pearson's decisive leadership in this fashion. Quote, these are McEachern's words, not mine. Quote, so it was in this atmosphere of provincial opposition and division within cabinet that Mr. Pearson finally decided that we would go ahead with the Medicare program. And without his decisive action at that time, because he finally made the decision, we may have lost the whole issue, end quote. Without his decisive action at that time. Friends, I say that Pearson's exemplary leadership is instructive. It was based on principle, and it built upon the vision and the principled leadership of Tommy Douglas and the CCF in Saskatchewan, as I've mentioned, and then Emmett Hall, chair of the Royal Commission, appointed by a progressive conservative Prime Minister, John Diefenbaker of Saskatchewan. What these leaders demonstrated was that national leadership is predicated on understanding and respecting our federation, provincial and federal powers divided, and most importantly, our nation's core basic underlying fundamental values. Of course, practical issues needed to be resolved. In Medicare's case, Ottawa's federal spending power offered 50 cents to the dollar to the provinces if they joined on to Medicare. That was the important condition, that they adopt the principles of Medicare, which were universality, public administration, comprehensiveness, and portability amongst all Canadians. And then later, when the Canada Health Act came into play in 1984, accessibility. And it worked. Within 5 years, every province, even those who had opposed Medicare, adopted the principles of our current Medicare plan. And this is a remarkable example of the promise of cooperative federalism and leadership, and not confrontational federalism, or as the word is used today in Ottawa, open federalism, meaning that what is assigned to the federal government is Ottawa's business. Provinces, you have no say. What's assigned to the provinces is your business. We have no say. Nothing can go ahead in a country like this if that is approached. But there will always be challenges. In the wake of Prime Minister Pierre Trudeau's changes, the funding formula in 1977, there was a dramatic lessening in the adherence to national standards, and the growth of extra billing and user fees was the result. Most significantly, however, Ottawa surrendered much of its authority to shape the future dimensions of healthcare service as new technology was coming into play and affecting its delivery, and accountability was greatly diminished. But to its credit, the Pierre Trudeau government, heeding voices such as Hall and Douglas, responded to these challenges and attacks by enacting, and very importantly, in 1984, the Canada Health Act, an act that articulated the fundamental principles of Medicare, and I still say is the charter of Medicare today in Canada. And then this was followed by a period of active enforcement of the principles of the Canada Health Act by Mr. Trudeau's minister, very distinguished Minister of Health, and a great friend, Madame Monique Béjam. Monique played an outstanding role in this regard. In most recent years, however, Ottawa has become more reluctant to involve itself directly in the shaping of much-needed new national reforms. Reforms which would strengthen Medicare, modernize it. And they've become reluctant to enforce the Canada Health Act at all. In fact, I think it's a forgotten statute. All the results in recent years have been disastrous, in my view. The CHA and Ottawa have changed from a strong sentinel of Medicare's values to a rooted, non-reactive stone statue. And all of this in the face of an explosion of new needs, new technologies, new procedures and new medications, demanding new modernization, which will only increase. So in response to my Royal Commission report of 2002, Prime Minister Paul Martin held a meeting of First Ministers in an attempt to rebalance all of this and the funding arrangements and spark changes to Medicare to take into account these new advances that I've alluded to. $40 billion over 10 years was added to the Medicare file spending envelope as a result of that conference, restoring the traditional levels of funding between Ottawa and the provinces. Unfortunately, however, no federal leadership was asserted to ensure that these new funds would be applied directly to home care, essential programs like electronic health systems, rural care, Aboriginal care, you name the areas that have arisen. Compare this to the Pearson model. Or, for example, lowering the costs of new pharmaceuticals, which are exploding, or implementing programs of well-being, upstream care, and wellness. In fact, it now is that the present federal government's policy has been to escalate the consequent decline of a modern, effective health care plan by ignoring it and ignoring federalism and ignoring the history. It's as though Ottawa's involvement has evaporated somehow, that the Minister of Health seems to be missing in action federally now. And I think in the result, Medicare is threatened like it has never been threatened before. It is as though the provinces in Ottawa live within two different universes. And if it sounds to you like I'm alarmed, I am. Of course, the current federal government argues that federalism is comprised of watertight compartments. What's 91 under the Constitution is Ottawa, 92 is health care, that's under the provinces, and that's it. They call it open federalism, as I've mentioned earlier. That federal intrusion into provincial matters for the purpose of maintaining strong national social programs does not deserve the best interests of Canadians, or does not coincide with the values of Canadians. Well, I'm here to say that this is a departure from our history, as I've tried to point out briefly, a history marked by the visions of great leaders like Pearson, Hall, and Douglas, and we need more than ever public policy firmly rooted, policy today firmly rooted in this tradition in order to modernize and to make more effective our health care services in Canada, lest this whole program disappears. So, where do we go from here? Let me sketch out what I think are 4 promising avenues for any new federal government after next year's election. A new government with a progressive agenda for change, informed by our history and values, as I've tried to speak about here, and built on our traditions. I'm under no illusion that Ottawa can do all or even most of the heavy lifting on health care. After all, I was a premier, and I know the challenges that reside still provincially. We have the primary responsibility for health care provincially. However, as I've already said, Ottawa's leadership is important. It must play a critical role here if we are to improve in these areas. And here are the 4. First, national pharmacare. The first reform, in my judgment, that Ottawa should make is to initiate the implementation of a national pharmacare plan, something that I recommended in my report, as did Emmett Hall in his report in 1964. This can be done by Ottawa in one of 2 ways: negotiating a pan-Canadian program with the provinces, by the way, that means cooperative federalism, even if it's tough negotiation, or initiating a universal coverage program on its own. There are advantages and disadvantages to each approach, but these challenges pale in comparison to the problems we face with the status quo. We need change. Now, according to a recent report of the Canadian Medical Association Journal, Canada is the 2nd highest per capita spender, get this, 2nd highest per capita spender, only after the United States of America, on prescription drugs in the world. 2nd highest. Yet, distressingly, we have the poorest cost control in the world, the poorest cost control, and between 2000 and 2010, we experienced the highest growth rate in drug spending in the world. Moreover, provincial governments are constantly being played by the pharmaceutical lobby. The result is an unacceptable variation in coverage of our citizens from province to province, depending upon the region and in the province they reside. But what of costs, some would argue? Well, according to the CMJA study and previous studies that I've alluded to already, a new pan-Canadian universal prescription drug plan would save Canadians at least $7.3 billion a year in costs. $7.3 billion. Yet, at a total cost to the public sector overall of an additional $1 billion. We have to acknowledge that. A report commissioned, and you'll be hearing from her in a moment, by the Canadian Federation of Nurses Union, Linda Silas, in 2014, made similar conclusions. The studies are out there. Moreover, this is one area of health care in which the federal government has a major constitutional foothold. In my view, it has the authority to establish a national pharmacare plan on its own, and with its potential buying power and its regulatory teeth to control prices and quality. All of these are federal. Even if the provinces want to continue with their own expensive and ineffective drug plans, we still need Ottawa's leadership to trigger the negotiations to establish a consistent top quality farm care program with basic national standards to ensure consistent coverage and effective price control right across the country, just as Pearson did and Douglas did and Hall did when it came to establishing Medicare in 1964 on a national basis. So I say the time now has come to expand, not to roll back on Medicare. Point number one, pharmacare. Point number two, facilitating the spread of successful provincial innovations. Ottawa's leadership is needed to break the current intergovernmental impasse on health care. They don't talk about it. Instead of leadership, however, what we've seen is the following. We've seen the elimination of the Health Council of Canada, gone, a recommendation of my report, leaving an enormous vacuum. It is often said that 13 provincial and territorial health systems form a natural laboratory in which the successful experiments and reforms implemented in one place can be transferred to another. Maybe. They say it can be transferred to another without incurring the much larger costs of failed experiments and reforms. Maybe. I would say the logic is essentially sound. However, in practice, we have very little idea of what is going on throughout the country. In all aspects of health care, we do not in any systematic way evaluate these experiments and innovations to healthcare reform to determine if they're worth replicating or building upon. This was certainly one of the functions of the Health Council of Canada that I envisioned when I recommended it in my Healthcare Royal Commission report. But having government members on the council, which is what happened after the report, created real difficulties in the evaluation of them doing the task of judging their own administration's competence to the overall plan. They were nominees of the provincial governments. So we need a radically different approach. Ottawa should provide the base funding for an independent evaluator operating at arm's length from governments, an organization that would draw upon the very best talent in the country, small, tight, very mobile organization, to conduct the rigorous and independent evaluations that are required. And to overcome the tendency of governments to avoid external evaluation, Ottawa should provide a modest innovation fund to assist in financing experimentation, but only if accompanied by an evaluation independent of both orders of government. I say this could serve as another tangible demonstration that not only Canada works, but that Medicare works too. So pharmacare, spreading innovation. Third, health and well-being, comprehensive programs. Our Medicare system, quite understandably, has focused a lot of energy and resources on primary and acute care. As the baby boomers age, it becomes even more pressing that we embrace comprehensive models of care. So we must modernize, I argue, our approach to seniors' care, develop home care, develop palliative care strategies, and others. All of these that honor the dignity and the needs of our population in accordance with the values of this great country called Canada, that we care and look after each other. Likewise, it is long overdue that we implement a mental health strategy in Canada, one that improves services and supports, but also a mental health strategy that ends the continued stigmatization of so many of our family members, friends, and colleagues. It's wrong. And friends, perhaps most importantly, we must start tackling the upstream factors that negatively impact upon our health and well-being, and which later on in life put such unnecessary strain on our Medicare system, both with respect to delivery and costs. For quite some time, the evidence has demonstrated that the key social determinants of poor health and well-being, from inadequate housing, education, low incomes, and poor nutrition, need to be dealt with because they impact on our health outcomes later. And one other important issue, the glaring disparities in health between, and I really want to emphasize this one, the glaring disparities in health between Indigenous and non-Indigenous Canadians is, to put it simply and bluntly, unconscionable It is a black mark on our shared Canadian values. And this has got to be a top priority given the leadership of our First Nations people and our Aboriginal communities. So, pharmacare, spending innovation, well-being with emphasis on First Nations and Aboriginal people. And finally, I would say upholding the Canada Health Act. Remember that? Do we remember the Canada Health Act? I do. This brings me back full circle to the issue of values. Upholding the Canada Health Act. One of the great strengths of universal Medicare is that all Canadians have access to medically necessary services wherever they live without any financial barriers. I can't think of a higher principle or goal. This is truly one of the touchstones of our Canadian citizenship, or at least it should be. One the Health Act is meant to safeguard. It is supported by a large majority of Canadians for the peace of mind that it gives them, for the fact that it resonates with our values, namely to know that their family, their friends, indeed all Canadians have access to care when needed. As I say, it builds on the values of our great country. This is one of those stubborn facts that just can't be eliminated or wished away by the opponents to Medicare, and they're out there. Opponents who want to return to access based on not need, but ability to pay. Some of those opponents have even publicly argued that Canadians have deluded themselves about the costs of health care. And they say one day we'll wake up to the fact that payment at the point of access will be absolutely necessary to keep the system sustainable. I say to those people who argue that, hogwash. All credible studies say hogwash. The Canadian public knows full well that Medicare is paid through our public taxation system rather than through private user fees, and I say they want it kept that way going forward as well. Still, in recent years, Ottawa has demonstrated a consistent lack of will to enforce the Canada Health Act. As a result, there's been an erosion of the principle of portability. Patients from one province are often forced to pay in advance for their medical care in another province. Can you believe it as a Canadian? And also the breakdown of reciprocal billing amongst provinces. This needs to stop, and one could go on. And in the last decade, we've also seen an erosion of the principle of access. Necessary diagnostic and surgical treatments can be more quickly obtained by paying out of pocket to private producers, which means more privatization. This too is an attack on Medicare and our values and needs to stop. So to summarize and to close, I argue as strongly as I can, we need a national pharmacare plan, an active and truly independent Health Council of Canada, comprehensive programs for health and well-being and wellness, and a determined enforcement of the Canada Health Act. And in the upcoming federal election, I ask all political parties to clearly lay out their positions on these important matters now, so we know where they stand and we can make an informed judgment. And friends, I close by the way I started. If the powerful examples of Tommy Douglas and Lester Pearson and Emmett Hall are followed, we can modernize and reform health care. We can give voice to our nation's values. And in the process, we can and will strengthen our great nation. Canada's values still endorse this great national enterprise. Let us recommit to this goal, and in doing so, spark pride and unity amongst all Canadians from sea to sea to sea. Thank you very much, and God bless every one of you.
Good afternoon. My name is Greg Marshallton, and I'm the moderator for this wonderful panel. And what we hope will be at least a brief conversation about the issues that have been raised by Mr. Romanow. And our first speaker will be Linda Silas, and she is the head of the Canadian Federation of Nurses Unions and a tireless advocate for its 200,000 members. She has been a negotiator. She has had decades of experience working with nurses unions, advocating in favor of nurses. But most important of all, for the purposes of this discussion, she has been a powerful advocate in terms of both protecting universal Medicare and expanding universal Medicare. So, Linda?
Thank you. And thank you, Mr. Romanow. And I'm 5 feet tall. My feet don't touch the ground, so it's good. I forgot to ask for a little stool. But mostly, Mr. Romanow, thank you for never retiring. You know, I'm always impressed. We need defenders of Medicare more than we've ever needed, and you were only 5 minutes over your time, so that was very good.
It's a miracle. It's a miracle.
It's that politician blood, and I'll stick to my notes so I don't go over my 5 minutes. But you know, my comments is mostly we need to get mad, and you started at the end. We really need to get mad if we're going to keep our Medicare system. You're a very statesman's-like speaker, and we've almost done it too much. We're too polite as Canadians. We're too polite with our federal government, and we have to get mad. I speak to nurses and healthcare workers every day, such as QP does, SEIU, NUPG. We're there in the ranks, as they say, and it's bad. It's getting worse and worse. You know, I just look at my membership, over 20 million hours of overtime. That's 12,000 full-time jobs, and we graduate 11,000 new graduates a year. In the last 3 years, they're not getting jobs. Does that make any sense? So there is an issue here. As healthcare workers, we want to make sure that we take the guards dogs out or the attack dogs out. It's important to get mad. Thomas said earlier, leadership is a question of choice. And I would add, not of a personal opportunity. And that's what this federal government is doing, don't get me wrong. It's a personal opportunity for the feds to close the door on health care, to make sure they're not part of these discussions, and they're letting all the premiers doing the hard work. Roy, we need to call a duck a duck. When it quacks and it walks like a duck, you call it a duck. And you need to call a quack a quack. For everyone who's saying our healthcare system is not working, you have the statesmanship to be able to say you're a bunch of quacks. Our conservative government are starving our healthcare system. Our provincial premiers have never been our best friend more than they are today, because they only have one option, is to cut and cut deeper. And some of you, he said it quickly. Did you hear that, people in Saskatchewan? He was Premier of Saskatchewan once upon a time, and you had to deal with the cuts of the federal government. Nurses didn't like you very much that time. I remember being on picket lines. You know, just saying.
Not as much as I remember you being.
But there's no, and the whole reason we're back in this mess and we're seeing more job action, more angry workers out there, it's because there's no federal leadership. This health department is like a facade. It's like an ancient historical building that we just pretty up and we don't do anything with it. Nobody could name our federal health minister, but they can name their provincial health minister because that's the person cutting their services. Now, I'm not going to talk about a conspiracy theory, especially with all the discussion around C-51. I might have a little guard waiting for me. But there is a conspiracy theory about attacking healthcare. What the government is doing, they starve healthcare, they cut programs, cancel surgery, patients in hallways. Imagine being a patient with a Johnny shirt in a hallway. We warehouse grandma and grandpa, and let me not forget, we make sure big pharma is richer. We forget about our Aboriginal health, and we forget that 1 in 5 Canadians need mental health services. And yes, they have a plan, the Conservatives have a plan that Canadians will start believing, I can do better by myself. If I get a second job, I'll do better. So my grandchildren, I want them to have the same kind of human rights and health care that I have, but we have to fight. You mentioned 2004. Remember 2004? We were lobbying every premiers. Make sure everything you put in the accord has strings attached. But no, there was no strings attached, and now we have what we have. The premiers agreed in 2004 for pharmacare. We were there with the premiers, and a lot of you were there in PEI with the premiers. They agreed again, we need a national pharmacare program. And we have to realize 1 in 10 Canadians can't afford their prescription drugs. I didn't know that, but 1/3 of our seniors, and that's a lot of people, 1/3 of them take medication that have been proven to be a risk for seniors, but they're still taking it. 6% of hospitalization are because people don't take their drugs. Look, we pay more for prescription drugs in this country than we pay for physicians. Ontario, this big, beautiful, giant province, get the best price. So the best price is they still pay 5 to 25 times more on generics. And this white tsunami, don't get worried. Look at Mr. Romanow, look at Mr. Broadbent. They are seniors, I've heard they're over 65. And look how healthy and well they're doing. But we need to continue those services. We will not all be 92 years old driving our cars, 92 years old playing racquetballs. We will need healthcare services, and they have to be safe. So on the health accord, honestly, and I have to wrap up, I'm seeing the signs here. On the health accord, honestly, do we need another government appointed, even if it be a bunch of scientific PhD people? What we need is strong branches of the Department of Health Canada, and we need maybe an Auditor General just for healthcare. I think we should recruit Sheila Fraser just for healthcare and really give the Canadian Patient Safety Institute more funding and more transparency and public reporting, and we'll do well. So again, congratulations, and we'll continue. Thank you. Merci.
That's the last time I'm going to have Linda follow me. Wonderfully said.
Well, I'm about to ask Jameson to speak, but and introduce you to Jameson, Steve. But first, I want to say that Jameson is a policy wonk like I am, and I'm sure he feels the same way that I used to when I used to have to follow Roy Romanow and he has to follow Linda.
Set up. Yeah, set up.
It is a bit of a setup. But I would like to just briefly let you know that Jameson is currently the Executive Director of the Martin Prosperity Institute and the Institute for Competitiveness and Prosperity at the Rotman School at the University of Toronto. He was previously an advisor to provincial government in Ontario, in particular, advisor to the Minister of Health here in Ontario at a very exciting time of reform. And he was also, for 4 years, from 2008 and 2012, the principal secretary. So he's a bit more than a policy wonk. Jameson, please.
Thank you so much. It's, as I prepared my remarks today following Roy Romanow, if that wasn't enough, I call for revolution from a 5-foot fireball. Now I just feel like I need to throw my remarks out and go. Having worked as Chief of Staff to George Smitherman, the notion of getting mad in healthcare is something I'm rather familiar with. Roy has provided an argument for Medicare that only he can, steeped in principles and values and history. And rather than try to build on that argument, because I think I would be a poor substitute or a poor second voice on that, what I try to make as well as part of the business case for why public health care needs to be protected and developed. And who I think of in this circumstance is my dad. I'm a kid from St. Catharines, always have been and always will be. And my dad would, on occasion, as a 74-year-old progressive in the city of St. Catharines, which is a tough gig to have from time to time, he once told me he got into a fight at the Y. And I said, how did you get into a fight at the Y? And he said, well, I was fighting over wait times. And I said, what happened? And like all elderly gentlemen in the gym, he was half naked against another gentleman, and they got into a wrestling match on the ground with my dad's final line before the fight started, which was, well, let's find out how long the wait time is for a fat lip. So I think of trying to arm that person with the right arguments and not just the principled arguments. Some quick numbers. Canadians spend $205 billion in healthcare in 2012. That's $5,911 per capita. Sometimes we forget that nearly 29% of that is private funding, mostly on the pharmaceutical side, which is a problem. And the word that I will keep coming back to along these lines is equity. There's not only interprovincial equity that Mr. Romanow is speaking about in the inequitable distribution of access to drugs or access to healthcare from province to province. There's two other equities that concern me. Those people who have money and those people who don't have money. And increasingly, I guess I'll speak on behalf of, I'll try to make myself a little bit younger, intergenerational equity. I really do concern that not only will I not have the healthcare that my father had, but certainly my 5-year-old son isn't going to have the healthcare that his grandfather had. And that's something that should alarm all of us and cause all of us to rise up. In our report in April, we demonstrated that healthcare spending in Ontario and Canada is well above the average of the OECD countries, but our province and our country lags virtually on every performance measure. That should bother progressives as much as the attack on the values, and that should be part of the arguments as far as why you move things forward. And I would argue the policy planks put forward by Mr. Romanow gather even more momentum when seen in that light, rather than just on the principled basis. So first of all, in the National Pharmacare Program, such a program would address issues of equity, as I say, not just from province to province, but intergenerationally. And we say in our report, the current pharmaceutical insurance system in Ontario and Canada makes little economic sense. The involvement of multiple players weakens purchasing power and increases wasteful spending because of a lack of drug assessments and private plans. And the present system fails in terms of social equity because a sizable portion of the population does not have any insurance, leading to increased costs on the healthcare side. I think these are useful arguments at a Progress Summit when we are not only just protecting and advancing our arguments, but trying to defeat others. I'm a recovering litigator, so I always think about these things and how you'd try the case. And trying to fight a right with economic arguments is a useful arrow to have in your quiver. Facilitating the spread of innovations. Perhaps I'd be a little bit more aggressive than what Mr. Romanow suggested on the national body. I'd actually advocate for them to be able to delist services if the technology no longer serves, and actually stop funding those times when best practices aren't being followed. It's not just something that's going to monitor. It should really try to drive some reforms. I look at the NICE organization in the UK as an example. It would be a huge leap from where we are today from a federal government to get that involved in the delivery of healthcare systems within provinces. So maybe a pan-Canadian approach would be better on that front. But driving real reforms. In Canada, in public policy, we're very good at carrots. We're not often very good at sticks. And in healthcare, that's maybe one area where we could probably improve. On the health and wellness side, again, and I'll be brief, what we've done on the mental health side and with the Aboriginal population is quite simply stupid economically. Forget the fact that it is egregious morally. We are not a big enough country to leave anybody on the bench. I am a March Madness fan. Think of everyone else in the world, and particularly our neighbors to the south, as Kentucky. They are undefeated, and they will beat us economically every time unless we hit every shot and every kid in our team is acting at their best. That's why we need a mental health strategy, and that's why we need to address the Aboriginal health population. Lastly, I would say three things. I would be one for, rather than just protecting where the Canada Health Act is, I think it's time to modernize, and it might be an interesting time to open up a debate as to what further principles and medical services might be required. But a less aggressive time, I would also argue, building off of what Roy said, there is a deinstitutionalization that has to happen in healthcare. The Canada Health Act at the provincial level, to a certain extent, drives you to think about physicians and hospitals first. Let's at least think about how a federal government could get involved in thinking beyond just those two initial partners on healthcare into some other models. It'd be interesting to see how a federal government could play. Secondly, a former Secretary of Cabinet in Ontario once said, at some point Ontarians are going to wake up to the fact that they have a small c conservative tax base and a progressive value set. That's a mismatch. We in our report talk about the fact that the Federal Department of Finance in Canada reported that the federal government foregoes $3.4 billion in tax revenue annually because of healthcare benefits not being taxed as compensation. Guess who usually gets those benefits? Those people who could afford to pay the taxes for those benefits. So I know there's been some proposals put forward today for around $750 million. I'm offering you $3.5 billion worth of funding that could be redeployed into other values. And lastly, perhaps controversially, if the federal government continues to cede policy ground to the provinces, partially because they don't have the money or they believe that Section 92 would prevent them from doing so, I would encourage provinces to seriously consider taking up the tax room that's been abandoned by the federal government. If they're going to cede the policy ground, then the tax ground should be picked up by others to fulfill the policy promises that need to be fulfilled. And lastly, the speech from Mr. Romanow was a roll call of the Hall of Fame of healthcare in this country. Hall, Pearson, Bégin, Douglas, and dare I say Romanow. I really hope that there's a generation coming up from behind who's going to pick up that torch, because I'm tired of talking about the past of healthcare. It's time to start talking about the future of healthcare. Thank you.
Are you going to say something? Well, I think it's time to begin the discussion, and I know Roy just poked me and said, are you going to say anything? And I think what I'm going to do is participate, if I can, in the discussion, but it's really among the three panelists here. So is there any particular issue that one of you would like to raise with what you've heard from the others? And we can start from there. Linda, let's start with you, perhaps.
I think it's important to realize what Jameson talked about. Yes, we need reform and we need to that big word, take it out of the institution, but we've tried, eh, Mr. Romanow? You recommended home care. You've recommended, talk about Aboriginal health, talk about community health centers. But governments don't follow through because they have to deal with the emergencies first. They have to deal with that heart attack that happens at the door. I'm from rural New Brunswick. I had a school nurse and mandatory gym class. Today they fund metal detectors and police officers in school. Like, we have a big problem because we just deal with the emergencies. We don't deal with the big picture. So you're right.
I guess what puzzles me is why a Pearson in a minority government, maybe the circumstances outside of healthcare were less important compared to today, somehow had the vision, putting it bluntly, the guts within the cabinet, I don't want to remake the speech, to force cabinet's approval. I shouldn't say force, influence, and then implement it using that carrot of 50 cents for all the provinces. Why is it that we don't seem to have this kind of culture or drive for something similar to make all of these changes that have been suggested effective?
Well, I mean, I think political opportunism to a certain extent, and I don't mean that in a cynical way. I mean windows of opportunity that present themselves. I think the politics internally in Pearson's party at the time were helpful to him, and I'm not sure right now. I was principal secretary to Dalton McGuinty at a time when even having a conversation with the federal government was almost impossible.
But I signed a document with Dalton. I think a very progressive document that McGuinty had.
So I think when you look at a time when there's a greater alignment, or at least a greater ability to have the conversations between levels of government, right now it doesn't even feel like there's the starting point of a conversation.
Watertight compartments.
Yeah, when the first ministers meet and no one from the federal government attends, it's difficult to read a resolution. It's as if all the kids go off to the room, come up with their demands, and then you get sent to bed with no dinner. You know, I think there's going to be a challenge going forward, but hopefully this. I continue to believe that our elections, more so than the Americans, still allow for policy conversations. And here's hoping that healthcare is one of those conversations that happens over the next 10 months.
All three of you have talked about federal leadership. I'd like to shift to provincial leadership for a minute, because as we all know, and as Mr. Romanow mentioned, the primary responsibility for healthcare remains provincial. And I run a little monitor which looks at reforms across provinces and territories. And the sad news is actually that there's very little other than the most incremental reform going on in the country. Why is this? Why are we in such an anemic state in terms of provincial reforms, particularly given that there's nothing in the Canada Health Act that acts as a constraint on provinces conducting just about any reform they want, as long as it's within these very high-level principles. What's going on?
Well, I can't have a definitive answer on this, but I want to respond, if I may, to what Linda identified, partly in jest, but mainly for real, knowing her. In Saskatchewan, when I was premier in 1991, all these many years ago, we were facing a fiscal crisis. But more importantly, Douglas's earlier documentation pointed to a regionalization of hospitals, namely the flood of new technologies, not only with respect to hospitals, but even the new technologies and medications required some form of rationalization of the plans. So a combination of us being broke, the idea, which comes from many, many documents that Douglas and his company wrote up, and just the explosion of what was developing was the motivation behind this. I really felt that what we could do is close down the 52 smaller hospitals which had limited capacity and convert them into that third component of my address, which was the upstream wellness concept. And there'd be meaningful positions where patients and people could come and visit, be treated by nurse practitioners who do most of the work in any event very often in every area going. I couldn't overcome that barrier politically. It was an attachment to the community. It was something more than that, an attachment to the right to health care, which I'm in favor of. I quite can't understand it even these 20 years later. I guess what I'm getting at is still, it requires some leadership to do something, whether it's that or something, I don't know what would be, well, I do think I know what is needed, and you have to ride through that storm. This is why I come back to the Pearson example. I come back to the Douglas example in Saskatchewan. They rode through that storm. Now reforms are needed. Why there isn't this view, I don't know. We obviously have a prime minister who doesn't believe in cooperation in implementing this. I don't want to say this in a partisan sense. That's the reality of the matter. So it can't be done nationally. Can it be done provincially? I don't know. I don't think so.
I think if I can ask and to clarify, we talked about lack of federal leadership. And that's when, even in 2004, and some of us were there in the negotiations right here in Ottawa, where we were asking the premiers, put strings. We were asking the prime ministers and the federal government, put strings to your reform. If you really want a home care program, if you really want a mental health strategy, as you mentioned, it has to be linked directly with dollars. And the federal government has to give the initial funding, because provinces are straps. The people are sick out there and they need help, so they can't expand. They can't look at community health and other programs. That's where we need federal leadership, and we have none. And it's getting worse and worse. That's why I say get mad, get those attack dogs out, get involved in the next federal election. And if you don't get involved in the next federal election, Jameson's 5-year-old kid is not going to, he's going to have pizza tonight. Yeah, it's his birthday party. But he's not going to have a healthcare system when he has children. And that's a reality. And it's not fear-mongering. I can see the Twitters out there. Silas is fear-mongering. Silas represents the nurses that are out there, and they're very concerned. And they will get very much involved in the next federal election, and we need to.
Complex. It's you know, we're getting our note that it's literally, as I'm about to talk, it's 3:16. So I will give a two-part answer as quickly as possible. Number one, the internal battle. So it's really hard to shift money from what is deemed to be urgent versus what is deemed to be important. To go over to the Ministry of Finance and say, I need to shift some money or create new funding for downstream cost savings. And the Minister of Finance says, I have a deficit today, and I'm having real trouble time getting back to balance. I can't, I need to save money tomorrow, not 5 years down the road.
But that's been the case historically too, and yet somehow we overcame that.
I think so. I think the way that deficits are viewed has changed significantly since the late 60s. That's number one. And number two is, I think the field is far more populated with people who will counter the reforms. I think, so therefore, I think there needs to be more fire on the burning platform when you enter the field of reform. Because now there's just so many people that will tell you why you can't. And as someone who's had the conversation come back to me, well, that reform might work, but people will die. We think nurse practitioners should do it, great, but people will die. Well, that's ridiculous. That's a ridiculous comment. But those are the type of opposition you face.
But remember, we all mentioned the National Pharmacare Program, and economists in this country are saying we would save between $4 billion a year minimum to $11 billion a year maximum. So imagine what we could do with that money.
I know that
real.
we're running out of time, but we may be heading for a major, I was going to use the word apocalyptic, but that's probably too dramatic, battle again about the values, principles, effectiveness of private versus public health care.
Yeah.
That's essentially where we're at. And I think if that's the case, everybody here is going to have to make a decision which side they're on and mobilize it.
Yep.
Yes, that's it.
Well, on that note, I wonder if you could all join me in thanking Roy Romanow and our panelists for this afternoon's great discussion. Thank you.
Pleasure meeting you.
Thanks for all the
You did, so did you.
You did very
You don't want to be on a stage with these folks.
well.